With me is Dr. C.S. Grover, sir, and I am Dr. Sananshu Mathur. So we start the first talk with lifestyle epidemic, ocular surface disease. Dr. Ruchi is here. Dry eye disease, preoperative concern and management. Ritu Arora is not here. I can't see her. Tissue Saxena. Who are the Suman? Vijay Suman Stogi, you can start evolution of pterygium surgery. Suture. You are here, Swati. मैं सोचा तुम भी नहीं है शायद तो मेरे बीच में. Suman.
Suman Bhartiya.
Suman Bhartiya, you can start. Suman. Sorry, I missed your name. Tricky limbal strip autograph. Minimal invasive pterygium surgery. Let us see what is meant by tricky.
This is wrong. Change it now.
Information to you.
It's not mine. Suman Bhartiya. Last one.
Talk number 4.
Good afternoon, everyone. I will be speaking on tricky limbal strip autograph, a minimal invasive pterygium surgery. The purpose of this technique is to minimize overall surgical time, destruction of the conjunctival tissue, then complication of other technique, and the recurrence rate, and to promote the early healing and to make it cost effective. Before going into detail about the technology, I would like to present my video first. So, after giving the perivalvular anesthesia, the head of the pterygium is avulsed from the corneal surface by pulling it toward the center and sideways. And after removal of the neck of the pterygium from the limbus, just try to cut the thickened portion of the conjunctiva with adjacent tendon tissue, showing tortuous vascularity. All has been cut. Then corneal is smoothened with the help of crescent knife. Then after giving the subconjunctival injection, the conjunctiva is separated from the deeper tissue, and every effort should be made to make the graft thinner. Then the graft is harvested, but not forget here to take the limbal area. So just expose the limbal area is very important. After proper exposure of the limbal area, this graft is separated after exposure. If any obvious bleeding is seen here, it can be controlled by direct tamponade. I personally don't use cautery. So this graft is separated from the base. After complete separation, some tissue are attached on the back of the conjunctiva. Try to remove it to make the graft smoothen. Then this graft is rotated and reversed. Taking care of that, the epithelial side should be upside and limbal to limbal orientation. After unfolding of the graft properly and placement at the limbal area, the both edge of the graft is secured at the remaining conjunctiva with the help of corneal forceps. Then at the end, the bare sclera is covered with the remaining conjunctiva. So the added advantage of this technique is we are leaving here the conjunctiva almost towards the normal anatomy. So we can perform the future surgery like trabeculectomy in these patients as we can do in the normal surgery like after SICS. So this is added advantage of this technique. So this is normal looking eye in the superior part. Now with the continuation, we all know what is pterygium, no need of introduction. Now we all know the drawback of the pterygium is recurrences. We usually take place within 6 months. And till date, the gold standard treatment for primary pterygium is pterygium excision with conjunctival autograft. I operated on 158 eyes with primary pterygium, all under perivalvular anesthesia. Now, the question is pterygium troublesome? Of course, yes, if the patient is symptomatic, especially when patient has the special concern of cosmesis. Now, these images showing the pre-op pterygium troubles to post-op cosmetic miracle. from pre-op day, intraoperative, then on first post-op day, 7th post-op day, then after the follow-up of 1 month. Now this is the image of the bihead pterygium of the same patient. These patients require slightly larger graft to cover the both sides of the limbal area. The first of day, 7th day, and after 1 month. Few more cases showing the limbal strip at the place. When I started this technique, I used to take the slightly broader graft in the first picture. But after few cases, I started to take only limbal strip, and the results are equally good. These are more cases after placement of the strip at the limbal area. These are the images of first post-op day. Then, these are 7th post-op day. These are all after 1 month. We can see the healing is quite good. We can see the limbal area is looking healthy. And these are it's a really moment of joy when patient comes after 1 month and showing lots of happiness. We can see the superior conjunctiva base look just like normal. This is the picture. It's a moment of joy especially. We can see in these picture the restriction of the conjunctival growth at the limbal edge of the limbal tissue, edge of the graft. You can see in last two pictures very clearly seen. The growth is restricted on the edge of the graft. So few challenges I faced during the surgery, like thickened graft, buttonholing, small challenges, which can be overcome by a slight modification only. Almost all cases of congestion on first 7th day, but all of it is resolved after the end of the 1 month. And graft edema, I observed when we start the surgery in few cases, but after that, I started the placement of the graft after drying up the base area. After that, I have no edema seen after that. In discussion, the conjunctival autograft with fibrin glue is superior than the conjunctival autograft with suturing, we all know. And the autologous fibrin clot with oozing blood has all the benefits of fibrin glue and suturing with added advantages and without any drawback. In routine conjunctival autograft, in which we need the larger graft to cover the whole the bare area, but in conjunctival limbal strip autograft, minimal destruction of the tonal tissue is there. So this technique has added advantage of planned future surgery like trabeculectomy, which can be performed in these cases as in routine patients due to near normal conjunctival tissue. To conclude, glue-free, sutureless, thin conjunctival or limbal autograft provides all the benefits of conjunctival autograft with suturing, having with extra advantages of the minimal cost and minimal foreign body sensation. All the advantages of conjunctival autograft with fibrin glue, avoiding all the drawbacks. And the conjunctival autograft without suturing, without glue, with added advantage of the minimal tissue destruction, early healing, and without any drawbacks. Now take-home message. The sutureless, glue-free, thin conjunctival limbal autograft using autologous blood is safe over other alternative techniques with early healing and minimal destruction of the tonal conjunctival tissue. So, this technique may be considered a viable alternative for the conjunctival autograft fixation in pterygium surgery without any additional drawback. Thank you so much, sir.
Congratulations, Dr. Suman. You really made the whole thing so easy. Your graph is showing the recurrence is very, very small.
Yes.
Can you tell in percentage in long term, what's the rate of recurrence?
What's it?
The rate of recurrence of pterygium.
Then nothing, no case after 158 surgeries.
And what is the length of study? In how many years?
1 year.
For 1 year, zero recurrence.
Yes, sir.
That's
Doctor,
great.
actually, we are doing this surgery. Dr. Ravindra from Bangalore, my close friend, he started doing this surgery, this minimal invasive pterygium surgery last 7-8 years back. When I visited his place in a conference that they were doing live surgery, I saw it. So advantage, she has very rightly thought, because we see the pterygium surgery operated by somebody else, come to us, we have to do trabeculectomy. We have to find out where we have to do trabeculectomy, from where they are giving the graft. When we start taking the graft, we find it is adherent. So we thought, so that is very good. Recurrence is important, sir, because we have to stop pterygium coming to the cornea only.
Yes.
So once we have some barrier there, so it will help us. Because whatever graft we give in 3 mm, 4 mm, 6 mm, 8, aim is ultimately to pterygium should not reach the cornea. When you have made a barrier may be small. अभी हम लोग आते हैं होटल के आगे वो बैरियर लगाया ना उससे बड़ी पतला बैरियर लेके रुक तो गए हम that the barrier होती जाता, we cannot enter inside. So this barrier, small, bigger, doesn't matter. Barrier is barrier, it will not help.
Very true.
We have not recurrence, we have almost do 6-7 years, we have no recurrence till now. Rarely recurrence in every case, even do bigger stabilium. But when you do bilateral, both sides, then what do you do?
Sir, we'll take a larger graft from the superior area, try to cover the whole area. So one
Like
case-
Maharajas may
Sir, one
length will remain same, but so you have to take.
Sir, in one case, I did the pieces of the graph and put.
So
just like
when we take up the long graph, but now what I have started doing it, I take graph from the lower. We have to take those both sides. We don't go to the other eye, but one graph from upper and one graph from the lower part of 6 o'clock, because we have to take very minimal invasive. Increasing the length of the graph, we take it from the two small graph. Thank you very much,
Sir,
sir.
in one case, I did the piecemeal.
You can do the
10
piecemeal.
cases, 5 and 5.
You can,
both sides, no?
sometimes the piecemeal do not have the cosmetic effect, because sometimes we retract and sometimes the effect of we have some issue.
Sir, in one case, we're very
Yeah.
wonderful. One
That's good.
aesthetically it was good.
You are lucky to have this.
Very
Thank you. So now we have Priya Suman Rastogi. He is a professor in Tirthankar Medical College, Moradabad, married profile surgeon. Evolution of pterygium surgery, suture to no suture.
First of all, I would like to
Ankit
thank
Agarwal is here?
AIOS
Yeah, I said
for
so.
having me here. So I'll be discussing about the evolution of pterygium surgery. That we have seen that how does this pterygium surgery has evolved. We have seen cataract, it has evolved from needle and couching to femto right now. But how does pterygium has evolved, and what are the recent concepts and what are the future concepts? So you've seen that my talk would be covering how the pterygium surgery has evolved, what is the current scenario, and what are the future concepts. So I am not going to the definition of pterygium, we all know it. It's a very common pathology, but the management is very less discussed, and it is frequently called as a surgery of residence. So we have seen the cataract surgery has evolved from ICC to femtosecond laser, but pterygium surgery has evolved from needle and thread eversion to pterygium excision with glueless, sutureless autograft. Coming to the historical background of the management, we had needle and thread eval technique, head transposition technique, then we have bare sclera technique, bare sclera with radiation and strontium 90, use of mitomycin C. But in all these techniques, something which was very common was the recurrence was very common. So, and in cases with mitomycin C and radiation, we have complications like scleral and corneal perforation, ulceration, secondary glaucomas, cataract and iridocyclitis. So in later half of 20th century, there was a concept of graft was introduced, and we had pterygium excision with amniotic membrane grafting, then rotational autografting, conjunctival transplantation, autograft with sutures, autograft with glue, double-head pterygium was with graft splitting, mucous membrane graft, etc. So coming to one by one, two few important surgeries, like we had a rotational autograft in which the pterygium was resected and it was rotated to 180 degree and it was implanted. But there was recurrence, too much of recurrence at that time. Then pterygium surgery with amniotic membrane graft, we did as our residents, we started with this surgery for the pterygium. Then conjunctival autograft with sutures, we have been doing it nowadays also with this procedure in like whenever we have the excess of glue is not there. Then till now in all the procedures sutures were required, most important thing, and it was cumbersome for the patient and surgeon both. Due to suture related problems like irritation, watering, pain and rarely sutural granuloma, patient's quality of life was compromised until sutures were removed. So the concept of conjunctival autograft with glue was introduced. But again, the high cost and availability of the glue was the problem. And I remember that we used to collect the patients for a glue and then take the glue, and then we used to operate the patients, like 4 or 5 patients in a session. So this was the problem with the glue. So so we require a new modality that can reduce the recurrence, they can reduce the availability of antimitotic drugs, irritation with suture granuloma, and cost involved with the glue. So the concept of pterygium excision is sutureless, glueless conjunctival autograft was introduced, in which we use autologous in situ blood coagulum as an adhesive for the graft. And advantage is that no suture-related complications and granuloma, less time consuming, cost effective, and less recurrences. So this is a short video in which I've taken this video after the removal of the pterygium. So you can see the graft is being placed over the limbal area, and it is being flattened. It's a quite easy procedure, nothing to be done much. Only thing is that you have to give some time to this surgery, little bit. And it has been placed over the limbal area, flattened, and just give some time, at least 2-3 minutes to get it settled, and then you can close the surgery. Nothing else is required. So there were different studies in past 4 or 5 years which says that sutureless, glueless limbal conjunctival autograft is a quite reliable method for surgery for the treatment of pterygium. And we did a retrospective analysis. Actually, it's not a study, but just analysis for past 6 years. We did about 522 pterygium removal with glueless, autoglass suture graft, and patients were followed up to 1 year. And we had about only 3 cases of graft rejection in 5 cases, recurrences in 5 cases, and conjunctival cyst in 2 cases. So it's a quite reliable method as far as this analysis is concerned. It's not a study, it's an ongoing, like we are still doing it, but just for the results sake, I'm just presenting it here. So this is the day 1 picture, and this is after 1 month. So the conclusion was that autologous fibrin in blood is a useful alternative method for graft fixation in pterygium surgery, having excellent outcome, being less time consuming, avoid suture-related problems, and cost of fibrin glue. This is a neo concept which is still evolving, that use of conjunctival tissue graft from the pterygium itself without rotation. So this is not in books, not in, like, it is still evolving, in which the surgeons, what they're doing is they're just taking the pterygium and removing all the subconjunctival tissue and just placing it over the limbal area. So it is like long-term results are still awaited, but it is useful in post-apectomy cases, both nasal and temporal pterygium, glaucoma cases with superior limbal conjunctiva where it is to be preserved. So this way, they just remove the superior upper part of the pterygium and place it over the limbal area, remove the subconjunctival tissue. So long-term results still awaited. I have not done myself any surgery. I have just found it in the research papers, but maybe this can be a future concept for the pterygium. Thank you.
Excellent presentation, Dr. Rastogi. I think this is the future, what you said. If you take the pterygium itself, clear the subconjunctival tissue and put it back there, that probably be the least hazardous to the conjunctiva. The whole anatomy is preserved. And that will have long-term benefits. Like you rightly said, the long-term results are yet awaited. May I request Dr. Ankit to please come for his presentation. Next is Dr. Neetu. Is she here? Yeah.
Hello everyone. The topic is sutureless glue.
So I wish to thank AIOS for giving me this wonderful opportunity to present. So my topic is sutureless glue pterygium surgery, the autologous blood method. Already 2 speakers have discussed wonderfully about the same technique. So I feel very embarrassed that I'm speaking about the same thing again and again. So I'll be showing just my surgical technique for this, and I will not be talking much about the pros and cons, because anyways we have discussed all those and I'll be saying the same thing again and again. So after removing the pterygium head by aversion method, just polishing the pterygium remnant from the cornea. Now, as we know, pterygium is actually a subconjunctival disease, so I'll just preserve the conjunctiva and remove the pterygium tissue from underneath it and cut it out. Now, using a corneal burr, I've tried to polish the remnants. We can see that this is a complication which happens with the corneal burr, that sometimes the conjunctiva might get caught and we might get this. Now what Dr. Priya Suman was talking about, the newest technique, I was trying to do this technique in this patient, but since the conjunctiva get caught in my corneal burr, I cannot do this now, so I'll just put a graft like a normal pterygium surgery. So the graft is taken slightly larger than the area dissected, so that it can be placed under the conjunctiva on all sides, This aids in preventing the graft from displacing in the post-surgical period. Again, we have to make sure that the limbal side is on the limbal side. Now I'll just leave it like this for 10 minutes, and after that just close the case. Gives wonderful results. This is another case. Same technique I'm following here. We're trying to remove all the remnant pterygium tissue from the limbal area. Cutting out the subconjunctival tissue. I don't use cautery in my patients because I believe cautery causes a lot of cicatrization and pain in the post-operative period. And autologous blood is actually really fast healing and gives least irritation to the patient also. Removing the excess fluids. Graft is well placed in the area. We just have to make sure that the limbus is on the correct orientation. Leave the graft there for 10 minutes and it will stick.
A very nice presentation, Dr. Ankit. How do you assure the stability of the graft?
So,
In how many cases the graft got displaced from its place?
sir, I did 34 cases in a year.
Okay.
We do a lot of charitable work, so for us having a glue was becoming a bit of an issue because these patients don't pay anything to us.
Finances must be a prohibition.
Yeah, and sutures, the patients started complaining after pricking and all these issues were there. So started doing this, and in my 34 cases in last 1 year, I have not had a single graft displacement.
That's very encouraging.
A few cases had graft contraction, but apart from that, there has not been any recurrence or graft displacement.
Very good presentation.
Thank you, sir.
I request Dr. Neetu, please.
Yeah, graft edema was there in a lot of cases in the first 1 week to 15 days, but they all resolved completely by 1 month. Huh? Yes. Okay.
That's true.
Okay. Thank
Dr.
you.
Stogie, you can join me here. Come. Dr. Neetu, please. She'll be speaking on management of cataract with pterygium, that cases we encounter quite often.
Good afternoon, everyone. Thank you, AIOCMT Scientific Committee, giving me this opportunity. So I am speaking on management of cataract with pterygium. See, we all know pterygium commonly occur in older patient, is usually accompanied by the cataract. Its prevalence varies from 0.7% to 31% in different geographical region. And removal of pterygium can be performed either before or subsequently with cataract surgery. So what are the challenges associated with the pterygium? So we all know the pterygium causes the astigmatism. The most common pterygium is the nasal pterygium, which causes the flattening of the horizontal axis, which increases with the ruled astigmatism. And because of this astigmatism, IOL power calculation is not accurate, and because of the pterygium, significant higher order aberration also seen. So what are the clinical consideration when we are dealing with the cataract with the pterygium? So which type of cataract? There are different types of cataracts: mature cataract, advanced cataract, early cataract, and there are the different types of pterygium: large flashy pterygium involving pupillary area, not involving pupillary area, small flashy pterygium, and the atrophic ones. But the most important is the patient's expectation. Some patients are very keen for the premium IOLs, and they want to very fine vision for the different distances as per the for distance, intermediate distance, and the near distance. So these are the patients we have to, and the other patients are the very comfortable with the minute deviations. Now, in this diagram, we can see here not only the length of the pterygium causes the changes of the ocular corneal surface, but the width and the area of the pterygium also causes the corneal surface changes. The recent study published in the American Journal of Ophthalmology 2024, it concluded that pterygium with a horizontal length of 1.7 millimeter and area of 4.45 millimeter square, and those with a horizontal length of 2.25 millimeter and area of 6.95 millimeter created 0.5 diopter and 1 diopter errors in calculated IOL power respectively. So there are two options: simultaneous and sequential. So as a rule of thumb, any pterygium of 3 millimeter or greater should be excised before cataract surgery, and patient with irregular Myers on keratometry or irregular central curvature or high corneal astigmatism on topography are candidates for the primary excision of the pterygium. And patient with the small pterygium at the limbus with regular Myers on keratometry, regular central curvature on topography, and low or absent astigmatism can have cataract surgery before pterygium excision. So there are the clinical scenario. One is the patient having mature cataract with the large flashy pterygium more than 3 millimeter. So we can go for the simultaneous surgery. So with the presence of the pterygium, cornea is flattened. So there is a post-surgery significant myopic shift. We have to reduce the calculate IOL power by the 0.5 diopter to 1 diopter, and the temporal or a steep axis approach would be better. Scenario 2, the atrophic pterygium less than 2 millimeter and any type of cataract. So we can go for the cataract surgery alone. If patient wants the pterygium surgery, we can do sequential. And the scenario 3, the patient has a large flashy pterygium and the immature cataract. This is pterygium causes the irregular astigmatism, and the other pterygium involving pupillary area. So in these cases, we have to go for the sequential pterygium. First one is the pterygium surgery followed by cataract surgery after 3 months. So what are the advantages of simultaneous surgery? Provide faster visual recovery, reduce hospitalization, cosmetic improvement, reduce loss of work days, subsequent reduced overall cost for the treatment. But the disadvantages are increased surgical time, increased post-op discomfort and pain, delayed epithelium healing, visual results may be suboptimal due to scar, and the refractive surprises may be seen. And the advantage of sequential surgery, it gives the better corneal stability and subsequent higher predictivity of IOL power calculation. Disadvantage, double surgery, double expense, double recovery time, and the double follow-ups. So surgery preferred, we have to prefer clear corneal cataract incision such as the microcoaxial phacoemulsification, and SIC should be avoided. And for the scar conjunctiva post-large pterygium excision, place the phacotunnel in a quadrant opposite the pterygium, such a temporal approach in the nasal pterygium. If there is a corneal thinning or flattening of the horizontal axis, to be performed phacoemulsification through the superiorly. Then what's the ideal time for the sequential surgery? So in this graph, this study published in the 2021, so in the first graph we can see here at the 6 month only 40% patient have the corneal astigmatic stability, and the mean keratometric stability get more than 73% cases at the 6 month. So if we are planning to monofocal or non-toric intraocular lenses, so we can, the ideal time we can go for the 3 months. But if we are plan for the premium IOS or the toric IOS, we have to wait for the 6 to 12 months. So IOL choice, it depends on the presence or absence of the corneal astigmatism. We have to do the keratometry and topography should be 6 weeks after pterygium excision, or preferably after repeated 2 weeks. And in patient without significant corneal astigmatism or demonstrable no higher order aberration, we can go for any intraocular lenses. But the multifocal IOLs and the toric IOLs are not a good options in an irregular astigmatism. So my take home message is that simultaneous pterygium and cataract surgery is necessary only in patients who can't easily access eye care facilities. In all other cases, we can go for the sequential surgery. But always keep in mind patient's expectation. Thank you.